Well, welcome to everyone. It's a pleasure to be here with you today and take the opportunity to talk about the relationship between social determinants of health and measurement of healthcare quality. I'm Dave Nerenz. I'm from Henry Ford Health in Detroit, Michigan. This is an area I've been working in and caring a lot about for up to the last 30 years or so. So I'm happy to share with you some of what I think are the core ideas and also talk about what some of the current controversies are in this area. To lay a foundation for this, I want to show you a little picture. What you're looking at here is a map of the St. Louis metropolitan area. The area that you see in red is sort of the downtown area and near downtown. But actually, and then it goes out to rural areas to the west from there. The color shading actually reflects degree of poverty. The red areas, the high poverty areas, the green areas are the level of lowest poverty, and then the yellow something in between. So you see the pattern's pretty clear, and the small little H's are locations of hospitals. So what you see here is a gradient of degree of poverty in various neighborhoods in the St. Louis area. Now, what's interesting is when you look at the comparison to this next picture, what we're looking at now, same metropolitan area, but now we're looking at readmission rates for hospitals. The point is obvious. These are essentially the same diagram. Obviously, there's an association. Conceivably, I could stop here, and most of what I have to tell you is essentially made in this diagram. There's a relationship. But I want to talk then about how this relationship plays out in the context of quality measurement in healthcare. It has been known for a long time that there are disparities in both health and healthcare. And there have been reports for at least 20 years on this. I've been working on it even longer than that. And it's important to note that it's a broad set of concepts, meaning that there can be disparities identified in a range of health and healthcare metrics. Treatment outcome metrics, population health metrics, process of care metrics. So the domain of health and healthcare is quite broad, and you can see disparities in many, many different places. But also disparity on the basis of what is a broad concept. There can be racial and ethnic disparities. There can be income disparities. There can be age, sex, gender disparities. There can be immigration status disparities, primary language disparities. So it's important to note that the word disparity covers a pretty broad range of territory, and a lot of it ends up being relevant to the domain of healthcare quality measurement. We live in a policy context now in healthcare where quality measurement is very important, probably more visible and active than it has been at any time in the past, particularly when it is used by public and private payers for purposes of financial incentives through pay-for-performance programs. CMS is very active in this area in the Medicare program, but private payers do similar things where one or more quality measures are taken up, they are compared across providers, and some form of reward or punishment is linked to those quality measures. This is done in order to incentivize improvement, and it works to some extent. But like almost any public program, it is not without glitches and difficulties, and that occurs when we talk about ways in which the payment incentive concepts are linked to some of these disparity concepts. This came up specifically almost exactly 10 years ago now, when researchers began to look at the effects of the CMS hospital readmission penalty program. It's a busy slide. The key point is what's circled here in the shaded little oval. Safety net hospitals were about twice as likely then, and still highly likely now, to be penalized in this program. Safety net hospitals more so than other hospitals. Question, is this right? Is this fair? Is this good? Is this as it should be? And just to give you another example, although a lot of the discussion in this domain is focused on hospitals and readmission penalties, that's not really the whole scope of it. What I'm showing you here are some examples taken from my own organization. We have multiple clinic sites scattered all over the Detroit metropolitan area, some serving relatively high-income neighborhoods, some serving relatively low-income neighborhoods. And what I've shown here, and I realize the font's a little hard to see, but these are some measures of diabetes care, some measures of cancer screening. And the key point is just what's shown in the slope of the line and the correlation coefficient. We have neighborhood household income moving left to right in all four panels, higher income on the right, low income on the left, and performance on HEDIS measures in these domains going from low to high. And obviously there's a relationship. And I mention this and I find it interesting because in every possible way that we can think of, these clinics are set up to be of equal quality to each other. Staffing, infrastructure, medical record system, presence of guidelines and reminders, in every possible way structurally that we can think of, these are comparable. They're designed to be the same. And if anything, the ones located in the lower income areas may have additional features, social support services available on site or active links, things like that. But we see this relationship. So when we talk about the relationship between health and healthcare disparities and quality measures used in payment programs, we see this kind of association all the time. So the concern is if entities serving lower income populations or otherwise, I suppose what we might term as at-risk or vulnerable populations, if they are more likely to be penalized, is that acceptable? Is that a good thing? Is that a right thing? And then a little more explicitly, the concern is if we don't do some form of statistical adjustment in these programs, the safety net providers may appear, but I think they do appear, to have worse quality of care than they actually do. And on the other side of the coin, those providers serving more affluent patients and communities may appear to have better quality of care than they actually do. The safety net providers tend to be punished and tend to be identified in public reporting as having, on average, worse level of quality. And the other side of the coin for those serving the more affluent patients and communities. And then what follows from that is that those providers serving the less affluent communities have fewer resources available. They may tend, in some cases, to move away from or avoid expanding into lower income areas. And that's an access problem. The very people who we care about, who we think are in need of the greatest possible resources to meet the health needs they have, may have the exact opposite happen to them. Either providers will pull away from serving them because they're incentivized to do that, or they will have freer resources available if they stay and try to do what their mission suggests. Now, there are some reasons that have been true in the past and are still argued for not doing some form of risk adjustment of quality measures or payments linked to those quality measures. And I've listed a few of them here. Some people have looked in and say, well, we could try to do some form of statistical adjustment, but if we try to do it, it just doesn't matter that much. We incorporate factors, social risk factors into adjustment models. They don't matter that much. It doesn't make that much difference. It's not worth the trouble. Or they could say, we don't know exactly why there's this association that we observe, and there's a risk that if we adjust for it, we may actually be adjusting away poor quality care. And that would be a problem. We don't want to do that. And I personally would not want to do that. Or it could be a problem simply with having data. We could feel, for example, that a factor like housing instability or food insecurity are important factors that might play into poorer measured outcomes and perhaps should be adjusted for, but we just don't have data with which to do the adjustment. So it'd be nice to do, but we can't do it. So these are some reasons saying for not doing some form of risk adjustment. I had the privilege, starting in middle of 2014 and then extended on into 2015, to be co-chair of an expert panel at the National Quality Forum. And we were asked to look at the then National Quality Forum policy that said, never ever do social risk adjustment of quality measures. It simply was not allowed in the NQF endorsement process. We were asked to look at that. We met as a group in person. We had a number of phone calls. And we recommended that that policy be changed. We recommended that measures be encouraged, or measure developers be encouraged or allowed to add some form of statistical risk adjustment for social factors into quality measures. And this was recommended to senior leadership at National Quality Forum, who in 2014 changed the National Quality Forum policy from forbidding adjustment to allowing adjustment. And I was pleased myself to see that happen. And nothing in this report said that adjustment had always to be done. It just could be done. And that has been the policy since that time. Now, I want to talk just a bit about, get into more detail about some of this pro and con argument. I know this, some of the print here might be a little hard to see, but basically this focuses specifically at healthcare outcomes and measures of outcomes. And it essentially just makes the point graphically that outcomes are determined by more than quality of care. The green shaded circle over to the right sideways is quality of care. And all you really need to do that is to notice is that there is something else. In fact, there are several else's. They can be community factors. They can be patient clinical factors. They can be patient demographic factors. There are a number of things other than quality of care that influence measured outcomes. And this is essentially the essential question of, do we or don't we adjust, particularly when we're looking at outcome measures. Now, this is a little different presentation, same idea, but this helps me make a little different point. If we're looking at outcomes on the right side of this diagram that's designed to show some causal factors, and we have patient factors, demographic factors in the lower left, the key question that we get into is, through what pathway or pathways do the demographic factors influence the outcomes and the measures of outcome? If the pathway that is labeled D and then G is the key, so that patients with certain specific social or demographic factors receive different treatments, or say lower quality treatments, and then as a result of that, you get a poorer outcome. You don't want to statistically adjust that away. That's an important thing you want to be able to see, particularly when you're measuring and then rewarding quality. However, if a significant path or the dominant path is the path labeled E, then you do want to adjust, because now these demographic factors are confounders statistically in measurement of quality. They affect outcome, but the causal path does not go through quality of care. The influence is through something else. Now, to National Quality Forum. The policy change has been evaluated formally now, and a report came out last summer pointing out how many measures had or had not had social risk adjustment applied to them. And I don't really have time to summarize all the results, except just to point out that measures are now being brought forward to National Quality Forum with some form of social risk adjustment. Not all that many, but some. And what we don't know yet is what happens out in the real world when these measures are applied, if they now include some element of social risk adjustment. We still have yet to learn about that. But things have at least changed to the point where measure developers are bringing measures through the endorsement process at NQF that have some element of social risk adjustment. Now, I point out these two side by side. The one on the left with the purple shading is a recent report from National Quality Forum specifically about social risk adjustment, a different expert panel. I did not happen to be a member of this one. Talking, again, in positive terms about the appropriate points at which social risk adjustment should be done, how it should be done, some of the criteria to evaluating whether it is being done successfully, but it essentially makes a positive statement. The one on the right is a report to Congress from the Assistant Secretary for Planning and Evaluation of HHS, the so-called ASPE report, second of two reports. It's very interesting. I commend it to your looking at it if you haven't had a chance to see it already. It goes through a great deal of depth, very careful empirical analysis to show over and over and over again in a variety of measurement contexts how dual eligible status, simultaneous eligibility for Medicare and Medicaid, basically defines the low-income elderly, is a factor that influences measured outcomes and other quality metrics. The surprising thing to me is then it recommended that dual eligible status not be used as an adjuster. I personally didn't agree with that. I wrote a piece in Health Affairs expressing my disagreement with that. But it is a report, and actually because of the tight tie between CMS and ASPE within the larger HHS structure, CMS is largely bound to follow this recommendation. So as a result, this debate goes on. It's been going on, continues to go on. There are empirical studies, I've captured some of these on the left side here, about either the impact of social factors on measures of quality, or now the effect of different approaches to risk adjustment. Do providers change rank when you do risk adjustment, or don't they? Do penalties change up or down? Do they become more fair or less fair? What happens to that? And there continue to be op-ed pieces expressing views either pro or con about adjustment. So the issues there, I think we know more about it now. We're much more richly informed about it now, but it continues to be controversial. So what do we know? We know that a variety of non-clinical factors, social, demographic, economic, have an effect on processes and outcomes of care. There's not much dispute about that. That association is there. There's a line of argument for incorporating these factors into statistical risk adjustment models, basically the same argument for why you do any kind of risk adjustment. If these are factors that influence outcome or other kind of measures independent from the actual quality of care that's being offered, they are statistical confounders, they should be adjusted for. The argument against basically involves people saying you don't want to mask disparities or exclude low quality care. And again, if you go back to the path diagram I showed you a little while ago, it's that distinction. Is it the causal path that runs through quality, or is it a causal path that does not? And we're trying to learn more about that. That to me is the heart of the debate. So happy to pause here. And if there are questions, I'd be more than happy to respond to them.